You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for March 23rd, 2018. This week, his bundle pacing, an antidote for factor Xa inhibitors, heart failure care, cardiac arrest, and myocarditis associated with cancer chemotherapy. First up, of course, is his bundle pacing. Now, the knock on his bundle pacing is that we don't have long-term outcomes. The skeptics say, yes, it's pretty and it's elegant, but does his bundle pacing improve outcomes? At the ACC meeting, we heard early evidence that his bundle pacing may reduce a composite endpoint of death, heart failure, hospitalization, or upgrade to CRT. Compared with RV pacing, his bundle pacing reduced this primary endpoint by 29% overall, and it was driven by fewer heart failure hospitalizations and fewer upgrades to BiV pacing. Now, I'll start with the caveat. It's an important caveat. This was a non-randomized observational study. You can't infer his bundle pacing caused these better outcomes. You can only say they associated with better outcomes. The results could have been due to chance or confounders. But as observational studies go, this is a good one. The patients matched up pretty well. The two systems are close in geography, that is, the implanters in the other hospital, which formed the comparator group, were experienced, and it's a reasonable comparison. And the notion that pacing the HIS and avoiding RV pacing-induced dyssynchrony could improve heart failure outcomes is plausible. Now, also in favor of this association being a real effect is that there was a gradient of effect. Now, what I mean by that is that those patients who benefited the most from his bundle pacing were those who paced the ventricle more. In this study, patients with ventricular pacing greater than 20%, his bundle pacing reduced the primary endpoint by 37%, here with an absolute risk reduction of a whopping 10% and a p-value that's highly significant. Of course, his bundle pacing requires effort. You have to take time to learn it. His bundle pacing may result in higher thresholds and maybe more lead dislodgements. It should surely be studied before using it as a substitute for BiV pacing in patients with left bundle branch block. But I'm here to tell you that his bundle pacing is doable, it's safe, it's elegant, and my 2-year experience now has been very positive. Finally, his bundle pacing requires only one special sheath. It uses an approved lead that has a great track record, and it uses a standard pacemaker generator, so it's likely to be cost-effective as well. Next topic is about factor X reversal agents. ANEXA-4 is the name of the study. Now, despite over 70,000 patients being enrolled in clinical trials of NOACs, or non-vitamin K oral antagonist agents, NOAC versus warfarin trials were done. All signals, stroke, bleeding, even mortality, favored NOACs over warfarin. Yet I still hear concerns about the reversal agent or lack of reversal agent for the factor Xa inhibitors. Now, that's why a report from ANEXA-4 investigators at ACC on the progress with adanexinet alpha is important. Adanexinet very rapidly reverses anti-factor Xa activity in actively bleeding patients, and this was the top-line result. Now, effective clinical hemostasis, the investigators told us, was achieved in 83% of these patients. Importantly, there was no control arm of this study. 227 patients were given the reversal agent, and that builds on the 67 that were reported back in 2016. Most of the patients who had actively bleeding that were in this trial received the reversal. They had intracranial hemorrhage at 61%, and 27% had GI bleeds. These were older patients with a mean age of 77. The reversal agent works. After patients taking rivaroxaban or apixaban received a bolus of the antidote, their median anti-factor Xa activity levels dropped by 88 and 91% respectively. Now, the 227 patients in this study, 2.6% or 6 patients had a thrombotic event within 3 days, and 24 patients or 11% had some sort of event, including ischemic stroke, MI, or venous thromboembolic event within the 30 days. However, the efficacy and safety, like thrombotic rate in Annexa-4, was similar to those in the reverse AD trial, which was the reversal agent for dabigatran. FDA is supposed to act on this agent on May 4th of 2018, and I think this will be a very important day for anticoagulation therapy. Next topic is heart failure care. Authors of the Get With the Guidelines registry presented another report on heart failure care measures during the ACC meeting. JAMA Cardiology published this paper, and it was analysis of 106,000 patients from more than 300 centers. And the analysis asked a simple question: is the mortality rate, adjusted for risk, of course, at 30 days, a predictor of long-term mortality? It's an important question because heart failure is prevalent. We have evidence-based therapies, and it makes perfect sense that adherence to quality care should improve outcomes. What's more, at least in the U.S., lowering rates of mortality, risk-adjusted again, for heart failure means better compensation. Now, I'll first tell you the results of this study, but then I want to tell you something else that I noticed in the tables that I think is far more important and really caught my eye. So first, yes, the 30-day mortality rate predicts long-term mortality at 1, 3, and 5 years. So therefore, looking at 30-day mortality as a guide seems like a reasonable thing to do. Of course, and anybody who practices medicine in the U.S. knows this, the huge caveat is that there's an immense gaming that goes on into risk adjusting these patients. It is the norm for me to get notices from our coders when I admit a patient that has heart failure as a diagnosis. And the push is to make these patients as sick as possible. So it's possible, conceivable, and I wonder about, is it the fact that the best hospitals in this study may simply have better coding and risk adjustment? My big point in this study, and I take a look at this, is in Table 4 in the paper. Of these elderly patients who are mean age in the low 80s, the unadjusted mortality rate at 5 years is 74% in the lowest quartile of performing hospitals, in the best hospitals, and 77% in the worst quartile of hospitals. Now it's 30 and 33% mortality at 1 year. So in other words, 1 in 3 of these heart failure patients will die at 1 year, and about 3 in 4 will be dead at 5 years. This, my friends, should be a call to action to get these patients a plan for symptom relief and end-of-life care and end-of-life discussions. Hope is a great thing, but it is not a plan. I think far more important, in my opinion, about splitting hairs about 2 to 3% differences in mortality rates in 80-year-olds with heart failure and comorbidity is recognizing that this is a call to relieve suffering in these patients who are nearing the end of their life. Fourth topic today, determining prognosis after cardiac arrest. This was an interesting study. The move to improve CPR and AED education in the community is really a good one, but one of the results of these efforts is that we are seeing more survivors of cardiac arrest. In most cases, a good or bad prognosis on brain recovery can be made in the first few days. There are, however, a substantial number of patients who we remain uncertain about in terms of their brain recovery. Will they awake or not? A multi-center study from the MRI coma investigators has found that quantitative whole brain white matter fractional anisotropy measured by diffusion tensor imaging between day 7 and day 28 after cardiac arrest can predict long-term neurologic outcome. Now, I know that's a mouthful, but it really basically, this is a way to do MRI scans on the white matter, and it measures the degree of water diffusion through the brain. And using a derivation and validation cohort of about 150 and 50 patients respectively, these MRI scans proved to be a fantastic way to prognosticate poor outcomes. Get this, compared with the standard measures of determining outcome, the diffusion tensor imaging had an area under the ROC curve of 0.95 to predict unfavorable outcomes. Now, in a subsequent validation cohort of these 50 patients, this test produced a negative predictive value of 71%, positive predictive value of 100%, 90% sensitivity, and 100% specificity for the prediction of unfavorable outcomes from a brain perspective. The authors call for this work to be validated in larger studies, but 100% specificity and 90% sensitivity for determining poor outcomes is a huge deal. This test could save lives, possibly identifying patients who might be late awakers, and it also could relieve tons of suffering in those patients who are kept alive needlessly on machines. I'm going to take this study down to my neuroradiologist and find out how hard these brain scans are to do. This is very interesting. Fifth topic is on checkpoint inhibitors. These are cancer chemotherapy drugs. Now, my friend Vinay Prasad was in town for a Grand Rounds lecture. He and my wife Stacy, a palliative care doc, were talking about the rapid expansion of the use of these immune checkpoint inhibitors. These drugs, Vinay said, can help small numbers of patients, but unfortunately doctors are overusing the drugs in non-approved tumors. A recent research letter published in The Lancet from a Vanderbilt group has noted a rising rate of fatal myocarditis from the drugs. Now, this makes sense, right, given the mechanism of action of checkpoint inhibitors. The idea is to, at least the way I understand the idea, is to unleash T cells on the cancer. The problem, of course, is that unleashed T cells can attack other organs like the heart. Now, the Vanderbilt team used the World Heart Association's database of individual case safety reports, and they identified 101 cases of severe myocarditis following treatment with these immune checkpoint inhibitors, and they observed an early onset of symptoms, frequent deaths, and substantially increased reporting of this problem in the year 2017. They found that nearly half, or 46% of the cases, were fatal, even among patients who were just taking monotherapy for checkpoint inhibitors. Now, among the patients who had data on the precise timing of when the myocarditis started in relation to the initiation of treatment, the median onset of myocarditis was 27 days, but the range was 5 to 155, and about 3/4 of the cases occurred in the first 6 weeks of treatment. I think this was a obvious thing to note in the podcast because this is an important complication of cancer chemotherapy, especially in drugs that may be being overused, but it's also really important for cardiologists to recognize that this is a potential complication of these drugs. And I certainly learned something from Vinay's discussion of this week here with us, and also from this interesting study from the Vanderbilt team. So that's it for this week in cardiology. I'm thankful that you listen. This is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.